so that there's all this follow-up. And you wonder, is this usual? For instance, have you ever encountered that kind of resistance to actual needed public health? You're going to administer some public health on people. And in those circumstances, there's a two-in-one question. What do you do? What can one do?
Yeah, so you see, what we call vaccine hesitancy is the refusal of people to be vaccinated, to accept that vaccines work, or believe that vaccines are intended for other political purposes other than the medical, scientific purpose for which it is intended. And it's not peculiar to Nigeria.
A very warm welcome to you. You're on to Kaftan Television, and it's the program The Conversations. I'm Nikki Atai, your host, and today we have a very interesting conversationalist. We are going to be looking at community medicine. Oh yes, and we also have not only a medical doctor in the house, but he is also multifaceted public affairs analyst and strategist. So we're going to be picking his brains on so many fronts. But for now, it's my pleasure to introduce to you Dr. TANKO YAKASAI. Welcome, Doctor.
Thank you. Good morning.
Thank you for joining us.
Thank you.
Okay, Doctor. I know lots of people would always say, oh, we want to go into all these professional courses, medicine, law, architecture. But in your own particular case, what inspired you to go into community medicine?
Well, thank you very much for having me. First of all, I will tell you what inspired me to read medicine. And then I will then cap it up with why I have to read community medicine, which is public health. When I was young, my mom took me to a hospital. And when we got there, it was a time when doctors close from work, and then the doctor that is supposed to be on call will report, so like shift. The doctor usually close around officially 4 p.m. and then the doctor on call will be available to be called anytime there is. So I think at that time I was running fever, and we went to the hospital and we waited. And unfortunately, before it gets to my turn, we were waiting on the queue. The doctor said that he needs to go. And so he left. We had to wait for the next doctor to come on board. So at that point in time, I was young, and I felt that the doctor should have waited until the next doctor comes on board to relieve him of his duty. Why would he go and leave patient? At that time, I was a young person, very young, a child. He should have attended to me, and I was feverish. You know how malaria...
It's children.
Your children, it can be high chills, rigors, shaking, high fever. So I made up my mind there and then that I would read medicine. I will become a doctor when I grow up. And if anytime I'm running clinics or I'm providing medical services, I will not leave until the next doctor who is supposed to take over from me takes over. So I think that has been in the back of my mind, and I studied hard to ensure that I have the necessary grades so that I will go to the university and read medicine. So that's how it started. Now, when you start medical school, you get exposed to different topics and different subjects, and by the time you come to the clinicals, which is when you cross to the hospital, you also get exposed to different specialties. And over time, I realized that my own way of life, my own natural ability to relate with people drew me closer to community medicine, because it allows you to go outside the four walls of the hospital and also interact with the community. So I felt that is the right profession for me, and specialization that I should pursue, because it takes me outside the four corners of the hospital. So that's how I picked interest, and I ensured that after I graduated, after my house job at NYC, I went back and did residency in community medicine until I become a consultant public health physician or community health physician. So that's a brief story about it.
Very interesting. But look let me pick your brains. At that time, right, did your mother make any comments like, "Oh my goodness, how could the doctor have just left us?" Or did she say anything? Or just in your young mind, you were able to see the total wrongness of the situation. Did
Yes,
she chip in and did she
I
say,
could
"Oh no,"
remember,
or did she beg? Could you just attend to him or anything?
When your mom takes you to the hospital and you
Yes.
are having serious
Yeah.
fever and you are shaking,
Convulsion. Oh
no
my
convulsion, but
God.
just your body is shivering and the
Yes.
temperature is high and you're crying, she would not understand when the doctor says his time is up and he will have to go.
My goodness.
So I remember they had conversation with the nurse who is ushering in patients and the doctor. Please, he should wait, attend to others. They had a conversation and she was trying to plead with him to ensure that he waits until the next doctor comes on board and let him clear whatever patients are waiting on the queue. So I remember, and I was watching all that. I was sick and I couldn't engage in the conversation, but it stuck in my brain. And my mother was begging and I was in that condition and we didn't get the attention that we needed, medical attention, and we had to wait for the next doctor to come on board. So my mother did that. She did tried her best to get him to stay, but I now understand.
Yeah, but that is so remiss now. That is so remiss. It should actually be punishable.
No, I think legally, when you are supposed to be relieved after your duties, the responsibility actually lies with the next doctor who should be prompt, make sure that he comes on time. Because if you have reported and you are seeing consulting patients from 8 a.m. in the morning to 4 p.m., because there are a lot of patients on the queue, the onus and the responsibility lies with the next person relieving you to be on time. But because the medical profession is a profession that deals with the lives of people and is service, even though it is within his right to say that he has met his number of hours, served number of hours, he should have been humane enough to remain until the next doctor comes. So now that I'm a medical doctor and I understand that sometimes when you sit and consult, your energy gets sapped and towards the end, you might not be in a position to provide quality care and attention to the patient that is coming next. And if you do not want to commit some clinical error of judgment in managing your patient, there is a time that you should be relieved so that the next person takes over who is fresh and do the right thing. Otherwise, you can do wrong diagnosis. You can be in a hurry to just quickly consult and you will not provide the needed time to go through history taking, physical examination, and all those things that we do to arrive at either diagnosis or differential diagnosis and run the tests and provide, the right treatment for the right condition. So I now understood that probably he would have been exhausted. His brain is no longer functional as an optimal capacity. So I don't think he will be sanctioned, even if we are taking it up.
Okay. What do you think are the skills in the experiences that make you a strong candidate for this role in community medicine?
Yes, so people have different personality types.
Yes.
And these personality types, are you naturally born with it. You can be an introvert, you can be an extrovert, you can be a happy person, you can naturally be the kind of person who melancholic, so, and you have all sorts of people with different personality traits and types. And so when you grow up, unless and until you pass through experiences, you may not likely fine-tune your own type of personality because you can learn to modify your own personality. Somebody can be an introvert, but over time, he can learn to be an extrovert. That is having ability to relate with people and want to interact. So my personality is such that even when I was young, I was not an introvert. I was an extrovert. I like to play. I like to interact with people. I crack jokes, and I find it easy to mingle with people, to live outside my environment. If I go to my family, other houses, I don't get reserved. I naturally integrate. I play in school and I joke, and so I realized that I am not a person who uh, is really an introvert or somebody who likes to hold on to himself or his own space. So some doctors have different personality styles before they get the knowledge. The knowledge comes after you are already been formed, in the university. And so there are different fields of medicine. And if you see children, you just stay in the hospital. You can just stay in your own space. You see children, you can be nice to them, but you don't have to be forced to relate with the general community. Internal medicine, a surgeon will just come, consult you and decide on the type of surgery, and then he takes you. But community medicine makes you intermingle with more than just patients.
Right.
The realm of community medicine cuts across health promotion. So healthy people like you, and you can tell you what are the things that you need to do to remain healthy.
Sure.
Preventive kind of policies or medicine where all these immunizations are intended to reach people to have immunization, build their immunity at a young age, so that diseases that are vaccine preventables, you can build your immunity. So prevention. So if health promotion doesn't work, health prevention doesn't work, then you have a disease or a condition. Then you come to curative medicine, where you get treated, and then if there are some sequelae where you have not fully recovered, you move to the last stage, which is rehabilitation. So community medicine easily cut across all these four spectra, and so if you are really happy, jovial type, and easy to mingle, you can involve in health education in the community. You are talking to healthy people, apparently healthy. It means going to the community, doing community entry engagement, trying to convince people of the importance and the value of certain medical advices, getting people to check their blood pressure, getting people to check their sugar level and other things. So this is beyond just somebody coming to the hospital who is obviously
already
sick, already ill, for you to engage. Community medicine is beyond that. It also involves policies. Federal Ministry of Health is responsible for providing policies that guide health delivery in the country, in terms of how do you set up the system? How do you engage and recruit the personnel that will deliver the services? How do you organize the services at the federal, secondary, and primary, secondary, and tertiary level? How do you ensure that manpower is available, the quality manpower, the right training? How do you ensure the right equipment for tier, primary, secondary, and tertiary are available? How do you ensure that the resources in terms of budget is also there? How do you manage information, the health management information system, to be able to, at a fingertip, press a button, and then you have all the information about health status of people in the country, so many other information that is there. So it's broad. Reproductive of adolescents and young people,
AIDS and all those ones.
HIV and AIDS, malaria, some of those diseases, they are easy to prevent when you follow ABCDs of their. So it's broad. And so if you are the person who enjoys talking to people, relating with people, going to community, you find community medicine a suitable profession or specialty to adopt and follow.
Okay. But how would you approach building these relationships, like with these community leaders, the organizations, stakeholders, so that you promote some of like what you were talking about, these healthy initiatives, healthy lifestyles, like are more preventable? How do you go about these relationship building, first of all?
Yes, so for every public health policy, there are strategies that you should deploy to deploy them. Some of these things border around social and behavioral change communication, where you have to develop what is the content of the message, who are your targets, How do you deliver it in such a way that they understand? Effective communication.
Right.
Now, this is something you do indoors. You get data, you analyze the kind of people, the nature of people in the community, and then design what health issues are you going to address? Who do they affect the most? Looking at the epidemiological aspect of it, and also looking at statistics. So all this will guide your strategy. Now, when you have the tool or this strategy that you want to deploy in the community, the next thing is how do you get into the community, which we talk about community entry. And community entry, before there are gatekeepers in the community.
Can I interrupt you there, please? The first part of it, right? Who are the people that you brainstorm with before the actual entry into the community?
First of all, there is government institution, Federal Ministry of Health, which has a unit responsible for health education, policies to be formulated, communication and social behavioral change communication unit. And so the government have units within their ministries that are responsible for that.
All right.
Outside the government, you have non-governmental organizations whose responsibility, or they've taken it upon themselves, that the funding they get and they deploy centers around these aspects of public health.
All right.
And then you also have community representatives. There is nothing you do without the representatives in the community.
Okay.
Religious leaders, youth leaders, women leaders, religious leaders. So these are gatekeepers, the people whom you need to pass through to get into the community so that you will be accepted. The messages will have meaningful impact and the messages will be accepted because, so when you have these different diverse people and you put them together, and there is a process, what we call a model of designing some of these programs and projects, what we call co-design or co-creation.
Okay.
Those who live the experiences, those who live in the community are in the room with the experts. And then you identify what are the issues and they contribute to, you provide the technical expertise, they provide the community context, and you co-create or co-design strategies, messages that you are sure when you go to the community to be accepted. So you need to do that. And by the time you do that, you have a package, you develop an advocacy strategy. The strategy, how do you reach each community? Because each community is different.
Yeah.
What are the tools that will be used to enter into a particular community? So the advocacy tools should also be community specific.
Yeah.
What you do, if you go to like my own state, Kano, YAKASAI, my own community, may be different from what you do when you go to Lagos and you are in Yaba or you are in Mushi Olosha. It's different from when you go to Port Harcourt, or you go to Edo. So the strategies have to be, targeted, taking cognizance of the community, their innuendos, their peculiarities, their differences. So by the time you get to the community, you go to the government before you get to the community, because everything you want to do in health, for State Ministry of Health, the local government primary health care department, PHCC, are all important in ensuring that you have government approval. 1, 2, the people in the community trust these people because they know that they are government and they represent their interests. And all those vetting takes place at that point. So together, you now go to the community. And when you go to the community, you start with the leaders. And like I have told you, community entry involves meeting the gatekeepers and ensuring that they are in tune with what you have for the community. And sometimes when you want to even start community dialogue, you can locate it in a place where they feel comfortable and they know they trust the system. So sometimes you take it to the traditional ruler's house, with TANKO, he tells you that there will be some team of health expert coming to talk to you. So where is the venue of the meeting? Traditional rulers institution, or the churches, or the mosques, or the youth, where you have youth, where they do town hall meeting. So there are different entry strategies, different stakeholder mapping that you do and you engage. And by the time you do all these things, you find that when you take the messages will likely be accepted. And over time, behavior takes time to change. And over time, with consistency and ensuring passing consistent and correct information, over time, people will begin to adopt certain healthy behaviors or whatever it is that you want to achieve.
Okay. Most of the time, we're always hit with this primary healthcare. So we're like familiar with what primary healthcare is, but could you let viewer know about the secondary and the tertiary, because you mentioned them earlier as these three levels of Medicare?
Yeah, so it's like a filter. Primary filter, secondary filter, and then a tertiary filter. Now, the essence of any filter is to, first of all, filter those things that will be sieved at that level. If anything escapes that first filter, it is expected that the next filter should be able to sieve it. And whatever escapes that first, the second filter, the third one should be able to sieve it or address it. Now, so primary health care means the simplest care that you provide where people live, where people work, and addressing common ailments that majority of people suffer from, so that you use technologies that are also simple. If a child has a diarrheal disease, the simple technology is to provide him with, replace what he's losing. If he's vomiting and he's passing diarrhea, replace what it is that he's losing, the electrolytes. So that's why oral rehydration solutions, what you call ORT therapy, or S solutions, simply addresses that. It's not a complicated medicine, but the technology is sound, and easily you can apply it. You either have the sachet, or the people can mix one teaspoon of salt and 9 teaspoons of sugar, and then it gives you a solution. The technology is simple. It addresses common ailment because children have diarrhea. If a child has fever, simply give antipyretic, what we call something that addresses the fever. Simple. So primary health care, antipyretic, that is like paracetamol. So primary health care addresses common ailments, and 70% of people who live in the society, their problems can be addressed at that primary care. And it doesn't require specialists. That's why if you have a community nursing officer who is employed at that primary care level, she should be able to provide that. If women are pregnant, and the beauty of primary care is that it is taken closer to the community. So all you need to do is just move from your house, walk less than 5 meters, or 10 meters or 30 meters, and you are in the facility. You do antenatal, they check if you are pregnant, what is it that you need. Simple antenatal drugs. It's easy to dispense. All those folic acid, hematinics, those drugs that gives you iron and things like that. And so primary care does that. Now, you can even measure your blood pressure to see if you have a blood pressure. You can also measure to see your blood sugar level. Easy. Now,
people are quite familiar with that level. But now we wonder what's the
second case.
I know, but I'm just saying people are very familiar with that level. But you've expanded it in a way to know that people will now know these and these and these are the broad spectrum of what you can expect at primary health level. And why I'm really emphasizing on this and even cutting it off, that people always go into the primary health center and they say, I'm thinking I need an operation for an eye cataract. No, that's not where to go. And again, we've noticed people always turn around and go to a place like a university teaching specialist hospital, and they say, last night I couldn't sleep well because I had a fever. No, that's not where to go for you to have a common malaria fever. You can actually go, like you said, to a primary healthcare facility, they can give you some anti-malarials at that level.
And easily they have rapid diagnostic test kits that they can detect if they have malaria. So the rule is that you test for malaria before you treat malaria. Because many people have treated malaria while it is not malaria.
Self-medication all the time.
And also the cadre of healthcare workers that man the primary healthcare settings
Primary level, okay.
Primary level healthcare workers, you know,
Yeah.
they choose community health extension workers, the junior and the senior,
The midwives.
the
And,
midwives, community nursing officers, you know.
yes.
So they can easily be produced in mass because it takes 2 to 3 years to produce some of these level of healthcare workers. And you can mass produce them, even though with strict regulation by the Nigerian Medical Council or the other regulatory bodies.
Yes.
So you see, because Nigeria is so big, population is so much,
Sure.
you need this kind of care providers to be produced, and it is even better if they are produced by the community.
True.
You get somebody who lives in the community, send them to these institutions like community midwifery. And then when the people come back, they are already resident in the community and they are not likely to leave the community. So you have skilled healthcare providers. So that's primary care level. Now, things that are beyond the primary care level, like what you call a standard referral system, where you know that something is beyond your skill set, and then you refer to the secondary level. Now, when you refer to the secondary level, if the system is efficient, there you will find many people who are treating ordinary diarrhea or malaria or simple cough, queuing up and taking the space in a secondary hospital. So there will be enough personnel that are skilled to address issues that could not be addressed at the primary care level. So it reduces 70% of patients that would have gone to the secondary level or tertiary level. So it frees up space for those who really need certain extra care that can only be managed at the secondary level.
Right, okay. So we're learning a lot. When we come back, we're going to look at the issues at the tertiary level, and then we're going to delve into so much more, because this doctor is actually a package of a personality. So just stay with us on Conversations and we'll be right back. You're welcome back. You're still watching The Conversation on Kaftan Television. I'm your host, Nikki Atta, and I'm talking to Dr. YAKASAI. Okay, we are talking mostly community health at the moment. So I would like to ask you, Doctor, how do you stay current with the latest research, with guidelines, the best practices? And again, how do you incorporate all this knowledge on community health into your work on a practical level?
All right, so you see, the training to become a consultant or a fellow of any of the colleges, either West Africa or National Postgraduate Medical College, is such that it's rigorous. And so you pass through the training, and then there are standardized procedures to follow, knowledge to get, knowledge to acquire, skills to acquire. But beyond that, and they do revision courses, and then you read books based on syllabus and things like that. So this guided, it's structured. But outside that, you know, as a professional, it is your responsibility to attend seminars, to attend courses that will give you additional knowledge to what you have, update your knowledge with the current trend and literature that is available in the field. And so there are seminars, there are symposiums that are also taking place. The colleges organize it, so you should be able to register and participate and update your knowledge. Then also there is an association of public health physicians where all of us belong to.
Okay.
And that association ensures that regularly it organizes seminars, symposia, workshops, you know, so that people will be updated, you know, on the current knowledge. Not only that, as a specialist, you are also supposed to be involved in research as a person. And when you decide on a topic that is topical, you read literature around it, and then you do research. So by the time you read a lot of diverse literature and you narrow down to a particular research question that you want to address, you would have updated your knowledge. And by the time you engage in the research, you are also constantly updating your knowledge. So these are avenues. And also, you know, the Nigerian Medical and Dental Council requires that before you update your licenses every year, you must have certain points, what they call continuing medical education, or continuing professional development. And those points are only obtained when you attend seminars, courses. So Nigerian Medical Association organizes that. Association of Resident Doctors organizes. So many of the associations under the medical profession organizes such seminars. And as somebody who wants to enrich yourself, be up to date, you have to identify these things, participate, attend virtually. Some of them are webinars, so you attend online. And that's in Nigeria, but there are also other regional platforms where they provide seminars, or international fora where they do that. So as a professional, you are supposed to constantly identifying opportunities to enhance your knowledge and skills. And so this is a way to be up to date. And also, if you are in a teaching hospital, your responsibility is to also teach young resident doctors who are in training, and also medical students. And so by the time you have a lecture note that is 2 years old, you know it's old. So you can't go and be teaching medical students something that is outdated, or resident doctor, because they also read. So it's your responsibility to know whatever you're teaching them, search if there is new knowledge or new information, and you keep updating your notes to make sure that you provide up-to-date information on the science of whatever you are teaching. So this is a way to keep abreast of the knowledge, and including the skills.
Yeah. Well, I know a lady who she's a nurse. She finished from School of Nursing and was practicing for many years as a nurse, and then she decided to go back to university to study nursing and public health up to PhD level. So she now converted from nurse to doctor, an academic doctor, but she's still on the field. Well, once I said I'd like to go along with her, and it was such an eye-opening experience. There were people who wouldn't, I think they were going out for this immunization. And I remember this was just before we had a lockdown. So this was in the year 2020. And sometimes they would tell people, these people were coming over, and they would shut down the whole compound, and they'd shutter the windows and everything. You can't come in. And there were young children in there, and they wouldn't let you inoculate their children in these villages. It's hard to believe. And then there's some other people who, we got the sense they were being very deliberate about not letting the children within the age range actually be available, because they had been told they were going to come that day, and then they went over to spend some time in a neighboring village place, and all this is being documented, so that there's all this follow-up, and you wonder, is this usual? For instance, have you ever encountered that kind of resistance to actual needed public health? You're going to administer some public health on people. And in those circumstances, there's a two-in-one question. What do you do? What can one do?
Yeah, so you see, what we call vaccine hesitancy is the refusal of people to be vaccinated, to accept that vaccines work, or believe that vaccines are intended for other political purposes other than the medical, scientific purpose for which it is intended. And it's not peculiar to Nigeria. We've seen globally where you even have a term, anti-vacciners, those who are anti-vaccines. Even in the US, and some of it is fueled by lack of adequate knowledge and information about the science behind vaccines. Sometimes it's cultural, sometimes it's religious, sometimes it's just conspiracy theory. People who believe in all this social media news going around against vaccine, and conspiracy theories are everywhere. And so when people are bombarded with information and they have no way of sieving the truth from false, they begin to reject or offer resistance to vaccine. And so in Nigeria, in some of the communities, parents have rejected or resisted vaccination of their children. And so the best way to go about it is to identify who are those that the community listens to, who are those that the community members trust. And when you reach those people, those gatekeepers that the community trusts, like the religious leaders. When the religious leaders, both Christianity and Islam, and you provide information to them, provide evidence that vaccines help, and they don't do what is rumored that they do, like affecting childbirth, restricting the ability for a lady or anybody to deliver, or it's a conspiracy by Western world to come and limit the population of Nigerians. And so once the gatekeepers understand, become convinced, then they will help you in providing health education in the community, reaching out to the community members. First, the traditional ruler in that community, the religious leader in that community. If they have children of vaccine age, they will first vaccinate their own children in their own houses in an open forum. And then the people in the community will now believe that if this traditional ruler or a religious leader or whoever it is that has a lot of influence in the community will vaccinate his children, then I believe and I will allow my children to be vaccinated. Two is to also show data. Community A has had significant coverage with vaccines, while community B do not have. And then, so when you have data that shows a lot of vaccine preventable diseases occurring in a community where there is no vaccination or there is vaccine resistance, the children have come down with multiple diseases, some have come down with debilitations, sequelae of the disease. Sequelae means you get a disease and it leads to something that may not allow you to function optimally. And the other community, have lesser number of cases. Let's say polio. Community A has a lot of people who have polio. Community B have a lot of their children who have polio. And you show data that this community, because they have accepted vaccine, they have less polio incidences. They have less children with diphtheria and all those diseases. Sometimes it helps. And then also sometimes you do pre-vaccine campaigns,
okay,
where you go to the community, engage the community repeatedly,
okay,
doing a pre-study, like focus group discussions, key informant interviews. This will help you qualitatively to determine what are the reasons for people rejecting or have often resistance to vaccine. In your development, as I told you earlier on, when you are developing messages, you address particular reasons propounded by those members of the community during that focus group discussion or a key informant interview. And over time, convince them that there is no negative effect arising from vaccine. So there are many strategies to address non-acceptance of vaccine, and it has been deployed and it has worked perfectly well in the past. So I think we are not there yet, but still the federal government, the state government, the local government, NGOs who are also working have helped in ensuring that people in the community are educated. And once you are educated, it will also reduce that vaccine resistance or hesitance. So it's multifaceted in terms of how you address that.
Okay. Wow, that was a nice piece of info. I wish it could get further out there to those who are, on the field, so that, because usually, like she was saying to me, the example I gave, they had just pre-informed them that this group was going to come. So maybe they could incorporate some of these good strategies you're talking about, like getting the community head to really emphasize and doing practical demonstration with his own family members, stuff like that. Like you said, that will actually be impactful, because, the way government is, like I sometimes say, is thrown at us, so much government thrown at us and not demonstrated. If you're saying do as I say, not as I do, it's a non-working model.
Certainly.
Okay, well, like I told you, the program is The Conversations. We're talking to Dr. TANKO YAKASAI. Let me tell you a little bit about Doctor. Doctor is somebody, you can get his number as easy as ABC, but every time you call him, there'll be like 10 people before him, 247. Oh, I have people in front of me, and or the rest of the time, maybe he's going to be somewhere in a meeting. He's a total person's person. He's a people's magnet. You just want to be with him. So he's so personable, and he's turned that skills actually into, I wouldn't call it lobby, but I'd rather call him like support groups. So as a matter of fact, he's going to also delve into, and we're going to pick his brains on the current administration. Like, at this point, this year marks 2 years of us being under the Tinubu administration, and he is actually in a support group. In fact, he heads one. So you're going to tell us a little bit. Let's pick your brains too on the political arena, especially of the Tinubu administration these past 2 years.
All right, thank you very much. My name, of course, as has been announced, Dr. TANKO YAKASAI. I'm the Director General of Tinubu Support Group, and what we do is basically support the president in the last election and also in the 2027 election. But also, beyond support, explain to Nigerians what are some of the policies that the president is doing so that they can understand. When you have policies that have long-term trajectory, sometimes it's difficult to understand because people want immediate solutions.
Right.
And it is the responsibility of this support group to constantly enlighten Nigerians on the intentions of the policies, the maturity period required for these policies to produce the necessary desired result and impact, and also talk about the initial successes that have been recorded. So that's what we do. And you have to contextualize policies to be able to understand. Let me give an example. If you look at the recent passing of bills that establishes several development commissions under President Bola Ahmed Tinubu, they are intended to bring development right to the doorstep of people. The way the Nigerian government and the federal budget is run is such that if a federal Minister of Education submits budget, the budget is supposed to impact the entire country. So if you are providing 1 billion for education, it should be equitably distributed across 36 states of the FCT.
Okay.
And it may not be enough to be able to solve problems of educational development in certain communities, because by the time it trickles down, it will be too little to produce the desired impact. And also, when you do a budget in Federal Ministry of Education, in trying to also be equitable, you provide resources, equal resources, to State A, who has a higher literacy level, higher standard of education, and you provide the same resources to another state that is at the lower rung of the ladder.
Yes.
With very abysmal literacy level, very abysmal standard of education. And so what you are doing is, it's like in a race. Somebody is at the 50-meter mark, somebody is at the 10-meter mark. And you just say,
both of them.
Go. What that means is that the person who is at 50-meter mark for a 100-meter race
must win.
Because automatically he only has 50 meters to run.
Right.
And then you are putting him in the same competition with somebody who's at the 10-meter mark or somebody at the 0. So when you hit the gun, you shoot it and say, go. Certainly, the person who's at the 10-meter mark will require 90 meters to get to the finish line. Somebody who is at the 50-meter mark would have only 50 meters. What of somebody who is at the 90-meter mark?
Yeah.
He only has 10 meters. So that's what you get when you put a budget in the federal ministries and you say you want to address health issues in the country. You want to address education. You want to address technology transfer. You want to address so many things. Now, the beauty of regional development commissions is that in addition to what is coming to health, these funds are provided for each of the regions. So Northwest can decide to say that in Northwest Development Commission, which indices are we performing poorly? And that Development Commission will decide to address those sectors that they are poorly performing.
Okay.
And they can ask governors, House of Assembly members, all leaders and philanthropists to contribute to addressing challenges peculiar to the region.
Right.
And nobody will claim that the president is doing a budget that is lopsided, because Northeast Development Commission will address probably desertification with their resources.
Right.
Northwest will address issue of health and education. Southeast will address issue of gully erosion and bad roads. Southwest already have high standard of education, so they may not deploy resources for education. They may deploy it for their own cash crops, production, road network to ensure that there is interconnectivity across all the 6 states. South may say that, okay, the problem is the dredging of the river or oil spills that which we address. So if people understand what President Bola Ahmed Tinubu has done with development commissions is to help people in the region to decide what is it that is their most challenge, what is it that they are most problem, and address it with that development commission. Who does that except President Bola Ahmed Tinubu? If we look at the road construction that is taking place, you also see that majority of the road construction that are taking place from capital to capital cities within the hinterland.
From capital to capital cities.
Yes, from Kano, it's a capital city, to Kaduna, another capital city, to Abuja, federal capital city. That's the way it is, to Benue. Now, because that is where most people fly, and that's where the highest complaints are. But if you look at the periphery of across the borders in this country, which is very, very large in terms of number of kilometers, somebody who is in Birnin Kebbi that needs to get to Lagos has to come down to Zamfara, Zaria, Kaduna, Abuja before he proceeds to Lagos. Or he goes through Yauri, Kontagora, Mina, then he goes to Ilorin to go to Lagos. Look at the time and the distance he has to cover to get to Lagos.
Israelite journey, they call that.
You can imagine.
An Israelite journey, yeah.
And everybody plies that road. Small cars, lorries, trailers.
Tankers, trailers.
Everybody.
Yeah.
Even excavators that were going for development work or construction, they fly that road, so they destroy the road.
Yes, yes.
Now, the essence of the Sokoto Kebbi Badagry express superhighway that the president has said, let us build it, is to ensure that you can move, you cut distance, you cut wastages, and you also open up roads so that majority of people who are going through Lagos can follow that route. And then it reduces the number of vehicles that follow this route that I have mentioned, and creates other opportunity. Do you know that without that road construction, everybody in that superhighway before now has his community unattended to? He has no visitors, and it's visitors that pass that create the economic activity for the people in the community. But before now, everybody passed this road and that place abandoned. Now there is economic activity going on in that road up to Maiduguri, and it's shorter, and before you realize it, you've already gotten there and people don't have, and this road are free. The same thing with the Calabar Coastal Highway. There's some other roads that are also being constructed. So this thing has a positive impact that Nigerians need to understand. The second one I want to talk about is financial autonomy for local government. The local government tier is the one that is closest to the people, because you have a councillor who is
closest
elected.
to you, a community-based person.
You have somebody who is elected as a councillor from his community,
right?
And he can never leave that community because the local government is in the local government headquarters is in the local government.
Right.
So he will leave his house, come to the local government headquarters, deliver his services or whatever it is as a councillor. He must go back to the community. And when he goes back, people can access him because they know his house. unlike a House of Rep member or state assembly member that will leave his local government, come to stay in the center because the House of Assembly is in the capital city.
House of Representatives.
House of Representatives, they'll even leave the entire state, come to Abuja, senators, ministers. So, local government chairman is in the community. But when you have the state government, as it is before, take all the resources from all the local governments, like in Kano we have 44 local government, 484 wards. Now these resources get pulled to the center, and the state government decides on the importance of certain projects and rank them higher, and feel that they are more impactful, and they would rather fund them with the state resources and local government resources. So what happens? What happens is that you take resources from far away local government, spend in the metropolitan area, and send them back peanuts because you feel that the center should look modern. But with the financial autonomy now, it means resources go back to the local government and they will be spent by the local government.
Right.
The chairman who runs away from the office because he doesn't have resources to give his people now has his own allocation.
Yes.
In my own local government, national local government, when I looked at the federal allocation, fuck, do you know how much money goes to my local government every month? About 1.5 billion naira. I can assure you, if I'm a local government chairman with just 11 councillors, because you have 11 wards,
yes,
you can decide to spend 500 million naira in each ward every month. You have 1 billion to keep at the center of local government, pay salaries of primary healthcare workers, primary teachers.
And even keep some aside, like for upcoming youths. But we know people like that are not thinking of that way because they were already handpicked. That's such a lovely futuristic model, but we've totally run out of time.
Sorry, but
so what will happen? Let me just give you
500 million every month.
I know. Let me just give
in
you
just 1 year
time to just say one last word to Nigerians. We're just out of time. It's a 1-hour program. It's so interesting.
So we've already spent 1 hour. So I want to say that to Nigerians, some of these policies are far-reaching, and if you give them time to mature, you will see the impact. Local government reform financial autonomy is to help the common man because resources will be provided at the local level, spent at the local level, not at the capital of the cities. If you look at the development commissions that have been granted, Northeast, Southeast, South, North Central, their intention is to limit resources so that it will address peculiar problems in that community. If you look at all these funds that are given, NEL fund, is to ensure that people who could not afford to pay their tuition fees are provided and the common man can go and get tertiary education. If you look at what's happening in the health sector, where primary healthcare centers are rehabilitated, the Federal Minister of Health is trying to ensure that in each ward, 2 primary healthcare centers are functional. Functional means the structure is there, the medicines are there, the right personnel are there, the right equipment, and making them 2 functional. And then they provide quarterly resources through the Basic Healthcare Provision Fund.
Right.
And also, if you look at the National Insurance Agency, they have tried to ensure that over 5 million people have been enrolled, and that will help them access care. So some of these are positive policies, and I'm sure in due course, Nigerians will see a greater impact and benefit. Thank you so much.
In due course, Nigerians should see greater impact, greater benefit. And I can see the passion in our doctor when he's talking, especially about these ones in the community. A functional primary healthcare center is the cry of everyone in every local government area, and everybody, every Nigerian comes from a local government area. So it's just been so engaging speaking with you, Doctor. Thank you very much. We can't pick your brains enough because you're so multifaceted. So what will happen? I'm still planning another program. You're going to come on. Thank you very much for honoring this invitation. It's been a pleasure bringing you the conversations today. I'm Mickey Atta. Thank you for staying with us. Till we come your way next time. Please remember, always keep it on Kaftan Television. Bye-bye.